Okay, so I'm going to talk a little bit about benchmarking, and the first question is, what is a benchmark? It's a standard or a set of standards that we use as a point of reference when we're trying to evaluate the performance or a level of quality that's being produced by an operation. And it's important to point out that we don't want this to just be the average performance. We really want this to be a level of excellence that you're going to judge yourself against. And you can draw your benchmarks from your own lab's experience, from another lab's experience, or a consensus of experts, and actually in some disciplines, even there are legal requirements that are put forth. Now, just as a bit of trivia, the term benchmark actually comes from the old British surveying literature or practice, where a chiseled mark was made in stone. It was a horizontal mark, and then they would put an angled piece of iron into that ridge, and on that they could place a leveling rod, and that benchmark assured that all leveling rods were always at the same, accurate level of accuracy. And so that's where the term benchmark comes from. Now, why should we benchmark? Well, if we want to improve care, then we need to be able to measure it. We need good ways to measure the levels of care. And so we need ways to quantify that. And with quantifying the quality of ECHO really depends on translating a lot of the recommendations we have for quality lab operations into a measurement. And in addition, as you heard from Jeff, some of the new payment systems, particularly in MACRA, have some components that really are going to require us to do benchmarking. So as you heard, that's going to be coming up next year that we have to have these benchmarks. So it's really now's the time to do this. Now, here's just an example from the European literature where if you looked at in different years sort of how certain medications were prescribed for both primary and secondary prevention, and those groups then looked at that each year, engaged against benchmarks. You can see that for a majority of the things, particularly beta blockers and lipid-lowering agents, there's actually improvement over time. So certainly, if you judge yourself against a standard, that should improve, you should improve your level of care. Now, when you benchmark, you can benchmark externally, which is comparing your lab's processes to best practices. And there you're learning from the competition, or you can benchmark internally. And many of the things that we do in the ECHO, it's actually good to benchmark internally, where you're just comparing different members of your lab against each other, or different groups within your lab against each other. And so you get a chance to learn from your best employees and hopefully raise the level of practice amongst everyone. And we're going to benchmark a lot of different things. We're going to benchmark lab processes. We're going to benchmark performance of members of the lab, and you can even benchmark your strategies that you're using, your business strategies. Now, in the business world and in industrial engineering, there's a whole science to benchmarking, and this is one of the more popular ones, and they take a 12-stage approach to this. But I've taken a much more practical approach to benchmarking, and instead of 12 steps, I really just have 3 steps, and I think this works in the ECHO lab. First, you want to select your performance measures. Then you want to collect your data, and then lastly, you want to compare your data to a standard or to a benchmark. So the first one is relatively easy. The second one's not too hard, but this third one is really the challenge, and for the majority of the talk, we'll sort of see why that's a challenge. So where do you get your performance measures from? So within cardiology, there are a lot of different sources. So for other aspects of cardiology, if you look in NCDR, there are multiple registries. There's a PCI registry, there's an ICD registry, there's a PACER registry. So within those, you can actually come up with benchmarks and performance measures. For, as you can see here, ACC and other organizations have written a variety of different guidelines and expert consensus documents. One here is on just quality CV care. There's another one on cath lab standards. There's one on EP lab standards. And in the ECHO world, I think the 2 major places you can go to look for your performance measures are the quality lab operations document that was put together by an ASC task force, published in JACE in 2011, and in the Intersocietal Accreditation Commission guidelines and standards documents that everyone needs to be familiar with when you're going up for accreditation or reaccreditation. I think in there, in both of these, there's lots of performance measures that you can use. So let's look at a few possible examples of performance measures and try to decide what the benchmark should be. So let's start with, here's a process measure. what percent of routine echoes, performed within your lab are performed within a certain number of hours or some time frame after that order. Obviously, for inpatients and outpatients, it's going to be different. But, and I don't know what that right number is. But once you decide what that time duration should be, you can look at how you perform. And then you really want to decide, well, what should be the benchmark? I mean, I just put up here, well, maybe it should be about 80% of your inpatient echoes should be performed within 8 hours of the order being placed, or within a business day of the order being placed. Or for outpatients, maybe it's 2 or 3 business days. But again, you want to be within your percentage should be within whatever that benchmark is that you set. And a much easier one would be what percent of all the echoes that are performed in your lab meet the appropriate use criteria set for echocardiography. Now, if you look in the literature, there's a lot of literature, at least from a variety of academic labs, that say that show that about 80 to 85% of the echoes that are looked at, whether it's for inpatients or outpatients, community-based or academic-based practices, about 80, 85% of them meet appropriate use criteria. So that should be your benchmark. Probably, 85% of the echoes ordered at your institution should meet the AUC. What about another lab operational issue? What percent of your sonographers have a valid credential? What percent of your docs are level 2 and level 3 trained? What percent of your physicians have taken the NBE exam and are certified? And I would say 100% of your staff should meet these criteria. So the benchmark here would be 100%. Now, we can look at other benchmarks in the lab, either for your lab as a whole, or you could look again, as I said, for each individual. So for uniformity or quality in imaging, you could look at what percent of the studies that each sonographer performs actually follows your lab's lab imaging protocol. And what percent of those are deemed poor quality. Obviously, we all have tough patients to image, but we certainly want to make sure that we're imaging at the highest quality. In terms of the quality of the data, what percent, if you have a stenotic valve, what percent of your echoes have a mean AS gradient that's within 10 millimeters of mercury of that mean gradient determined by an invasive measure? And you could do that for other stenotic valves. For stress echo, you could look at what percent of your stress echoes are reported as positive, where the coronary angiogram or the coronary CT confirms that finding. And then I guess the question is, what do you use as a marker of significant stenosis on that other imaging? Is it 50%, 75%? And that's sort of a discussion we probably need to have a different time. And then another benchmark might be on those stress echoes. Of those positive stress echoes, what percent have a wall motion abnormality in the same location or in a location that matches the coronary lesion? Again, we can have a positive stress echo, but if we call it in the anterior wall and the lesion is in the RCA, yes, we called it positive, and luckily we got the patient to the cath lab, but in fact, we may not really have been making the right call. And then you can even, amongst your physicians, measure the uniformity of interpretation. You can give your entire staff the same echocardiogram and see how close in terms of the interpretation do you come. And again, what should that level of variance be as a benchmark? So my goal is not to sort of say what the benchmark should be, but to make you think about what performance measures you should be using, and you or your lab should decide on what the right benchmark is. And lastly, in terms of communication, of the inpatient echoes that you sign off on, how quickly are those reports available? Obviously, the IAC guidelines say that the final report should be available within 24 hours after the completion of the echo, and for outpatients, it should be available by the end of the next business day. In some institutions, such as mine, our requirement by the network is actually even shorter time than that. And then obviously for stat echocardiograms, you'd want to have a much different benchmark, performance measuring benchmark. Now, lastly, as Jeff mentioned when he talked about the MACRA, there are 2 ways to get paid in the future. One is going to be the AMPs, the alternative method, but I think most of us are going to be under the MIPS. And that MIPS score, as he showed you in that pie graph, 50% of your MIPS score is going to be determined by a quality score. And that score then is going to determine whether you get an incentive payment or whether you get a negative adjustment. So, and to me, the most distressing thing is that it's next year's practice performance that's going to be measured to determine how we get paid in 2019. And the reason I raise this is that if you look in that very long document, there actually are some components of the quality score that actually apply to echocardiography. They have a whole section on cardiac stress imaging that doesn't meet appropriate use criteria, and 3 particular areas where taking patients who are low-risk patients who are going in for low-risk surgery and doing imaging stress tests on them for preoperative evaluation. There's routine testing after PCI when patients have no symptoms. They've done very, very well, and it's just a routine practice. And then asymptomatic low-risk patients routinely getting that annual stress imaging test. And these are measures that the government has decided can be used to determine how high a level of quality your lab is practicing. So even though we don't control who gets those tests, we're going to have to play a much bigger role in explaining to our referring physicians who should be getting these tests, because all of our livelihoods are going to be at risk or be adjusted based on some of these measures. So this is a reason why you need to benchmark. In the future, again, as has already been shown on some graphs, there's going to be public reporting of quality and performance, and so CMS is going to be showing how you stack up. Other payers are going to be showing this so that they can send their covered lives to labs that perform a quality product. Patient advocacy groups are going to be publishing your benchmarks, your lab's benchmarks, and even the Echo Societies has done that. In your registration packet, you all got the MedAxiom ASC survey with some benchmarks there. Interestingly, there's a lot of great things to look in this. One of the things that caught my eye is that only 74% of practices expect the reading physician to look at the old echo and compare the old echo to current echocardiogram. I think that's a relatively low bar, and that certainly should be much, much closer to 100%. But anyways, in here, lots of things that you can look at and use as benchmarks when you're comparing your own lab's performance. Also, I think we're going to see benchmarks linked to outcome, both clinical outcomes and financial outcomes. Obviously, the financial one is a big piece when you heard about what Mike and Jeff talked about in terms of, I think, the forces to reduce unnecessary echocardiograms and reduce waste in spending. So the keys to successful echo lab benchmarking, I think, are several. One is that you want to define the performance measure. I would keep it as simple as possible so that it's attainable, feasible to measure. You need a good tool in your echo lab to make these measurements and to get the data. So a good search tool. I can tell you that some of the newer commercial electronic medical records are much harder to develop good search programs for than some of the old systems that we used to have. So that's going to be a challenge, and we need to force the vendors to really get the search capabilities that we're going to need. You want to make sure you're collecting the right information, and I like to do frequent assessments. So what I do is I do a laddering technique where I don't look at all the quality measures at one time during the year. Every quarter I look at a different measure. So in one quarter I'm looking at communication of reports. In another quarter I'm looking at the quality of the images. In another one I'm looking at how accurate the interpretations are. So in every 12-month cycle, I'm looking at all of them, but I'm not just doing them all at one time. It makes it a lot easier to do. So that's the way I would recommend doing it. And then you want to figure out a diplomatic way of communicating these to your staff, because you want your team to learn and be enthusiastic about these measures and not consider it a penalty. We need to communicate this to raise the bar, raise the level. So in conclusion, there's many ways to benchmark. I think in the Echo Lab, I would encourage you using the established standards that are published by the IAC and by the ASE. Keep your targets reasonable and attainable. There's going to be more and more agencies that are going to require us to do this. So this process is going to continue to grow, which unfortunately means there's going to be more administrative burdens on your lab, which means you need to think about having the personnel to do this. And with that, I will thank you for your attention.